problem I think a lot of doctors make and a lot of surgeons make is they look at the scan, they look at the x-ray, look at the pathology. Yeah, we can fix that with an operation. And it's not that simple. You have to take into consideration lots of other factors. Patient mental state, physical state, what kind of support have they got in the background? What are their expectations moving forwards? And a patient, and looking at the x-ray, she needs an operation. But as a person, she is not a surgical candidate. So I've fine-tuned who I operate on, when I operate. I think my patients understand that, because not everybody needs an operation straight away, or even needs it at all.
Hey everybody, and welcome back to another edition of the Physiotutors podcast. Today we have with us Dr. Ahmad Malik. Ahmed Malik is a consultant specialist orthopedic surgeon in foot and ankles. He works at the London Foot and Ankle Clinic and has over 2 decades worth of experience now. Not saying you're old, but Dr. Malik, take it away. Why don't you take 1-2 minutes, introduce yourself, and then we're just going to dive on into the topic of today.
Yeah, thanks. I'm feeling really old now.
You're welcome.
I am older. Cheers, bud.
You look fantastic.
So, yeah, I'm a doctor. Graduated in 1998 in Glasgow from University of Glasgow Medical School, which is my hometown. And then very early on, I think I wanted to be a surgeon. So I trained in general surgery and then got onto the surgical rotation and then wanted to specialize in orthopedics, despite hating it in med school. It's funny. It's a long story there. And then, I just loved orthopedics. And orthopedics, you know, my higher training was down in London, came down for 6 months. The rest is history. The black hole vortex of London sucked me in and didn't spit me back out. So I specialized in foot and ankle disorders, foot and ankle surgery. And I've been a consultant since 2011. And I love my job. What can I say?
Lovely. Glad to hear it. But obviously you and I got talking maybe about a year ago about trying to get you on the podcast, something like that. And one of the things that really piqued my interest in the content that you were putting out was your not just pushing surgeries on everybody you see, and you're very open with your patients about the best option for them. As physios, we see a lot of people coming in and out of our door, and to an extent, there's a bit of you don't make a recommendation for the patient. The surgeon will make the recommendation whether or not to go through with surgery, even if we have an idea in the back of our head that this person may benefit from conservative treatment and the surgeon says otherwise. But I found that quite interesting, and the fact that you were so open with it. Can you maybe talk to us a little bit about what guides your decision with your patients as to what's optimal to operate or not to operate? Because at the end of the day, people in the States will say that, hey, this decision to operate is going to affect the bottom line. And in the UK, I imagine it's much the same.
Yeah. For the sake of your listeners, I think we should clarify, and I'll chance to plug myself in here. We got in touch through Instagram, and I don't really do social media I don't really like Twitter. It's a negative space, and I don't really do Facebook. I like Instagram because I've always loved taking pictures and photos. I love the visual aspect. And for me, it was never, people say, oh, is it marketing? You're trying to get patients? No, to be honest, it's my little diary. And it's an opportunity for patients to get a window into my life, build a rapport, stay connected with my patients, and put out content that can help people. So that's why I use Instagram. And that's, I think, how we connected. And you thought, what's this crazy guy doing? I need to get in touch with him. So, something like that, yeah. Yeah. I think you've asked a really good question. And the thing is, it's very new. It's very complicated. Like, how do you decide when to operate on someone? Who should we operate on? Who should we not? And I think a lot of my practice comes from my own personal experience. I've been that patient. I've had several orthopedic operations. I've been through the decision-making process myself and dealing with surgeons. And I know what it's like from the patient perspective, and I know what it's like from the surgical perspective. And I can tell you right now, the problem I think a lot of doctors make and a lot of surgeons make is they look at the scan, they look at the x-ray, they look at the pathology, go, tick, yeah, we can fix that with an operation. And it's not that simple. You have to take into consideration lots of other factors. Patient mental state, patient physical state, what kind of support have they got in the background? What are their expectations moving forwards? And take, for example, this morning I had a clinic, I had a patient, and looking at the x-ray, she needs an operation. But as a person, she is not a surgical candidate. So I've fine-tuned who I operate on, when I operate, and I think my patients understand that, because not everybody needs an operation straight away or even needs it at all.
Absolutely. But what made that person not a candidate for surgery as a person, and yet their imaging would say otherwise?
Okay, so take, for example, there's several points. One, not everyone has the same amount of symptoms for the degree of damage that you might see in a scan.
Yep.
So now we're talking about subjective symptoms and objective hard findings. So, in surgery and physio, we grade things 0, 1, 2, 3, 4. We can scale it up. We can score it. We can make a percentage. We can score it out of 100. Whatever. You can call it just 0, mild, moderate, severe. There's a variety of different ways that we can grade. Objectively, we look at an image, a scan, or whatever, try and, put a label or number to it. Now, what I found over the years is that doesn't really correlate with patient symptoms. So you can have someone with bare bone knee arthritis, tibia, femur on the tibia, and you ask them, so what are your symptoms like? Yeah, I got a bit of stiffness. You're like, oh, wow. And then you get someone with scuffing of the cartilage, minor cartilage damage, little bit of pathology on the scan, mild. When you ask them what your symptoms like, severe. So yes, scans and images are important. They're for the diagnosis, for the grading of the severity of the problem, for monitoring disease progression, for monitoring therapeutic intervention, prognostic planning, lots of different things. But in isolation, can you plan treatment? No. It has to be done in correlation with the patient's subjective symptoms. So what I normally draw a graph for my patients. So I start off with the question, look, you come to me, you tell me your foot's painful. If 100% is a normal foot, you can wear whatever you like, you can run around, do whatever you like, wear whatever shoes you want. It's a totally normal foot, looks normal, feels normal, 100%. How normal does your foot feel? Some of my patients will turn around to me, like the one this morning, and say, it's kind of like 75% normal. I go, okay. And then I say, let's have a look at your x-ray. We look at the x-ray and I go, how normal do you think your x-ray looks like compared to the other foot? Because we always have a comparison with x-rays. And the patient will go, oh, wow, I can even see that. That's really abnormal. I'm like, yeah. What number would you put that out of a scale of 100? And they'll be like, God, that looks like 25% normal. I'm like, oh, there's a rub. So now you've got a subjective assessment of 75% normal, but objectively looking at your hard scans, that's only 25% normal. Now, the problem is there's a gap in our expectations then. So say I operate on the patient and, it's all about me and my ego. I operate on them. I do a great job, patting my back. And I think I've taken them up to 95% normal. So 25 to 95, let's do the math. What's that? 70% gain? I think I've done a pretty damn good job. Now that patient thinks that they started off at 75% and go up to 90%. That's a 15% gain. So here's a surgeon going, wow, woohoo, I've done an amazing job. And the patient's thinking, what, all that for 15%? Same x-rays, same patient. But we're having two totally different appreciations of what's been done. So I really need that gap to be like pretty much zero. Like we're both on the same page. Now, why is that patient up there? And why am I, the x-rays down here? This is the number one question. Like, pain is a fascinating topic, and I'm still learning about pain. There are psychological factors, stress, sleep, physical well-being, previous experiences with pain, hypersensitization, head trauma, you name it. There's so many other factors in play. But the reality is that gap has to be, we need to be on the same page before I'm going to take on that patient and operate. So this patient this morning had the 25% x-ray, but feels 75% normal. And, when I spoke to them and said, what do you want me to do? And they said, well, what does surgery entail? I give them a rough outline. Oh my goodness, 6 weeks. There's no way I can do this. I'm very active. Now, the next patient that came, and she's going to be on my Instagram account because I thought it was hilarious, also has the same condition, same complaint with 25% normal x-ray. And when I said, right, you're back now, here's your x-rays, blah, blah, have you had time to think about it? What would you like to do? Oh, God, yeah, I want the operation. I went, oh, wow. She goes, yeah, because my foot feels 25%, it looks 25%, I've had enough, I've tried all the non-operative stuff. And I said to her, but what about the 6 weeks? Are you not worried about the time off and blah, blah? And she goes, 6 weeks, that's a blink of an eye. If it means I've got 3 decades of a normal foot, 6 weeks is nothing. And you see, it's all driven by the patient's subjective symptoms. She thinks she's 25% normal. She will do whatever it takes to get better. The other person thinks they're 75% normal, and frankly, is a mild nuisance, mild problem, and she's not willing to really sacrifice an amount of time to get to where she wants to, because it's not that big a deal. And that's where I think it's very important to really pick the patient at the right time. Now, not having surgery for her is going to cost her. And that comes to another conversation about the fact that it's not just surgery that has complications. Because it's, a lot of people physically, mentally can appreciate surgery, complications, infection, bones not healing, whatever, whatever it might be. What a lot of my patients don't factor in is that non-surgical management also has complications, and that's then what I talk them through. And the thing is, I need to educate my patients, explain to them all the pros and cons of whichever decision they choose to make, empower them, and they then ultimately need to make a decision as to what to do next.
Interesting. What are the non-operative complications that you come across with your patients? I think that as a physio is really interesting.
Yeah. Well, I mean, take, for example, I don't know, did you, like in nursery, sing the toe bone's connected to the foot bone connected to the eye? Yeah, remember that? But as adults,
rings a bell.
Yeah, but as adults, we kind of forget that. And, you would never think, as a foot surgeon, what's the foot got to do with anything else? What I've realized is that it's got to do with everything. Our human body is an incredible machine, which is designed for a reason. And if something doesn't work, it will have a knock-on effect on everything else. So when you have a problem in the foot and ankle, for example, and it's left and becomes chronic, you start developing adaptations, compensations. You start walking differently. You try and offload the area that's damaged. That in turn overloads other structures. It introduces abnormal gait patterns, which then creates further problems up the kinetic chain. I've seen patients with hallux rigidus, which, if your listeners don't know what it is arthritis of the big toe. Because they're taking the pressure away from the big toe, present with stress fractures in the metatarsal, present with chronic ankle instability because they're rolling the ankle out all the time. I've even seen patients with knee arthritis, with lateral joint overload, because again, they're swinging their foot out, causing a genovalgum, your varum. Your physios will know about this genovarum, where you're really bowing out your knee, and they've basically worn out their lateral knee joint. So by the time they've come around to the idea that yes, they need their foot dealt with, they've actually ended up having a knee replacement as well. And I remember this chap was only 40, and I was 40 at the time, thinking, oh my God. He goes, yeah, I've had this problem for 15 years. I had someone operate on it to try and buy me time. It was called chilectomy. It didn't work. It made it worse. That put me off surgery even more because they had a bad experience. Left it, knee got in trouble, that the back was going off, it goes on and on and on. So you get maladaptive responses. And then the problem is, even when you fix that problem, you then have to unwind all the learned compensations. You need to learn almost how to walk again. You have to gait retraining. So it's not even the case that, you fix the problem and that's it. So take, for example, my roof and my parents' roof up in Glasgow. So when my father had cancer, we brought him down to London. And for a year, no one went back up home to Glasgow. Now, if anybody listening doesn't know where Glasgow is, it's in Scotland and it's very wet and rainy pretty much every day of the year. Now, when my dad passed away, one of the things we had to go up was settle the kind of estate and everything. And we found that there was a leaky roof. There's a tile out of the position. It leaked through the window, flooded the attic, flooded my dad's bedroom, mum and dad's bedroom. The ceiling had collapsed, ended up costing £25,000. Not great when you've just buried your dad. Okay. Oh. Now I came and it was a messy affair, took a long time, blah, blah. Now, the first thing I did when I came back home was I looked at my roof. I live in a 300-year-old cottage. First, I was like looking at my tiles. And I called a roofer, and the roofer came and said, "What's the problem? What's the emergency?" And I said, "There's no emergency." He said, "Why have you called me?" I said, "Can you just climb up my roof and just see if anything's wrong?" He went, "Really?" I went, "Yeah." He went up, came back down. He went, "Yeah, you've got 3 loose tiles. I've slotted them back into place, and you've got a hornet's nest, and this is a number you should ring to deal with." And it cost me 50 quid. He went, "You know what? It'd be really good if a lot more people did what you did, and they'd save themselves a lot of hassle. Give me a shot again in 3-4 years' time." Yeah. So what I'm trying to say is, if you leave a problem a long time and let it fester, it's harder to fix, it's more complicated, it's more messy, and you probably end up with a slightly less desirable outcome than if you intervene early. Take, for example, when you have joint deformity, or when things get damaged, ligaments are torn, tendons fail, you've got severe arthritis, and you start losing the structural integrity of your foot. And we really want to compare left and right, because the feet are meant to be symmetrical. So if there's asymmetry and there's an acquired deformity, that's not good. And when that happens, everything starts to get out of alignment. Bones start to get out of their natural position. Then you start getting adjacent joint disease, other types of arthritis. So yeah, you might fix the underlying problem, but then guess what? You've got other stuff to deal with as well. So this is just touching upon some aspects of complications of non-operative management. And I'm not saying it happens to everyone, but I'm saying that's a risk, and it can happen.
Okay. But then if we just take, for example, we pull that right back to the start of it, and we just take, for example, this idea of the whole gait pattern changing as a result of a hallux rigidus. Now, the human body is very, very adaptive. Someone might argue and say, yeah, okay, so you're going to walk a little bit differently, but your body can also adapt to that walking differently. So it's not going to potentially be the reason that someone got arthritis in the knee because they were walking slightly differently, because their body can adapt to it, and it will adapt to the difference in tissue loads. This is a big thing in the physiotherapy sphere, where biomechanics aren't the cause of an issue that someone has. If someone's kneeing in while they're doing squats, that's not going to be the reason for their knee pain in 5 to 10 years' time. So is there any more clarity you can give there?
Yeah, I think that's a great point. And the truth is, yeah, you're 100% right. The human body's incredible. And we can tolerate so much that's thrown at us. If you just look at the food that everyone eats, the crap that we're eating, and their body still detoxifies it and sorts itself out. The smokers out there have been smoking 50 years and don't get lung cancer. There's an incredible physiological reserve, and your body can adapt and compensate, absolutely. But there'll be a minority of people who can't, and the adaptation won't work, and the compensation will not work, or it'll work to a point, and then patients will start to feel or have symptoms. But like I said, again, it's all about pain perception as well, tolerance, pain tolerance. Why is it some people with the same noxious stimuli have absolutely no pain, and some people are in agony? I just don't understand it. No one understands it, and it's an area that still people are trying to figure out. So it is very, very complicated. But I think function does matter. Biomechanics do matter. I see a lot of people with deformity, with symptoms, and if it looks like a foot, it'll work like a foot. If it doesn't look like a foot, it's very unlikely to be working properly. Does that make sense? And
Yeah, and that's
used
a
to,
really interesting point there, actually. If it looks like a foot, it will work like a foot. So another big thing that's come to the fore in the last few years is shoes and the shape of shoes and the effect that that can have on feet. Now, is there much to be made of a narrow toe box or a wide toe box? Is there anything there?
yeah. So I actually posted this recently on my Instagram. You probably missed it. So look, there's this definite movement, barefoot walking, barefoot shoes.
Those Vivo shoes, yeah, yeah, yeah.
I was going to say the brand, but yeah, you said
Yeah.
it.
I'm trying to get him to sponsor me. I want some free shoes there.
Good luck. Good luck for that. Yeah, so you've got that whole movement, okay, and then on the other side you've got trainers and all the specialist trainers and foam and rocker soles and metal rockers and God knows what and carbon plates and all that kind of stuff in there. It's complicated. Look, I think I probably sit somewhere in the middle. Do I think walking outdoors barefoot, doing deep squats, and having turmeric milkshakes is the answer to life? Probably not. But do I think we should all be wearing shoes all the time and they have to be this brand? No. So, like, if you saw me right now, I'm barefoot. I walk around the house barefoot all the time. I encourage my children to be barefoot all the time. I exercise and train barefoot. I feel my balance is much better. I think it improves my balance, the proprioception, doing all my body weight exercises and getting the mobility and the flexibility, working my intrinsics. I think it's so much better than wearing a training shoe and the foam cushion. I don't like it. So I really believe you should use your foot. It's designed in a way for a reason. I've forgotten the name of there's an image that shows the brain sensory input, and I've forgotten the name. Oh God. Anyways, the tongue and the head and the
The
hand.
homunculus.
That's it.
Yeah.
And the foot's got a massive, part of that picture because it's a sensory body. Now, having it shut in shoes all the time, I think you're denying it that sensory feedback. I think that's going to have an impact on your balance. Working those intrinsic foot muscles are really important. I often pick up the toys are lying around with my feet. I work my toe muscles, I work my foot muscles, and I think I have a stronger foot, stronger balance, and a stronger, that's my foundation building upwards. So 100% for sure. But look, am I going to walk around the streets of London with bare feet? Oh my God. No. And the thing is, like, if you grew up in a village in Africa and you're running out there, over the years, your skin becomes as thick as leather. If you look at these people, they've got hard, thick feet, like they're wing shoes. They don't need shoes. Now, you look at my feet and stroke them, they're soft as a baby's bottom. I can't be running outside. I run cross country. I can't be running cross country with my bare feet. It's just, it ain't happening. So for me, it's somewhere in the middle. And the reality is, over the centuries, we've developed footwear for a reason. It is protective. It allows us to travel further and faster in certain terrains. So I think it's finding that happy medium. I'm not going to say they're right and they're right. I think it's a bit of both.
Do you think that the narrow toe box can cause effects and deformities?
Yeah, so technically, when you speak to foot and ankle surgeons, when I was training, all my bosses used to say, "Oh, shoes have got nothing to do with bunions," and it just happened, which is 100% true in the sense that yes, people with who don't wear shoes, they can still develop bunions, and we don't really know why you get bunions. People with inflammatory conditions like rheumatoid, they can get bunions, but some of it's heredity, some of it's congenital. My mum had it, my aunt. So it's not that simple. However, I do think footwear does matter. If you look at the shape of your foot, it comes back to, if it looks like a foot, it'll work like a foot. Why is our foot designed the way it is? The toes are the way they are. They're meant to have that space. And if you then squash your toe box, squash your toes, well, I think you're going to irritate the nerve that results in mortis neuroma. You're cramming your toes. That's putting your intrinsics under strain, your plantar fascia. And the thing is, a lot of people will say, oh, but I wear these and they're really comfortable. I think two things are happening. One, people are either just getting used to their feet being in that squashed position, or two, slowly with time, they start to stretch out the fabric and material of the shoes. And I see so many people with shoes and they're lumping, bumping, all over the place, and you can tell the shoes are just stretching out. And this whole then concept of you need to break in your shoes, I think is ridiculous. I go by the philosophy of when you wear a pair of shoes, they either feel great or they don't, and also they need to be appropriately sized. And I think oftentimes the shoes are right up against toe box, and it's not meant to be like that. It's meant to be at least like a centimeter off, to give you room. And people think, oh no, but isn't it too big then? No, it's not. You need to have appropriately sized shoe in length, in width, and it has to be comfortable from day dot. And again, another problem that I find is people say, well, my shoe size is this, and that shoe was very uncomfortable. I didn't like it. Well, if you go next door into our utility room, you'll see I've got a 7.5 narrow shoe, 8 standard shoe, and 9 wide shoe. What does that tell you? It tells you my foot isn't changing shape or size. The shoe companies have different shapes and sizes. And what you should do is wear what is comfortable, and your shoe size is what is comfortable for you, not a number. So use the number as a guide, but play around. And again, I think the problem is when I go physically into a shoe shop, and this is coming from someone who, worked in a shoe shop. My dad had a shoe shop, by the way. There's a limited number of stock in the back. Keeping stock is expensive, and, you only have a certain number of sizes. So when I go to shoe shops, or when I used to, I found that I would say, oh yeah, this feels a bit tight. And they'd be like, oh no, just give it time. You need to walk it and it'll be fine. Because maybe they don't have an 8.5 in the back, and they just want me to buy the 8. Yeah, and that kind of conversation. Whereas I think nowadays with the ability to buy online, a lot of people are free returns, free delivery. I always say to people, buy shoe size up and down, walk around, and if it feels great the moment you put your foot in it, that's right for you. But if you're like, something's not quite right, send it back. And okay, there's a bit of an inconvenience sometimes. But with my latest running shoes, it was my 4th attempt, before I got the pair that I was happy with. Now you might say, maybe you're just really fussy. Maybe I am, but my feet are important to me.
Yeah, agreed. It's funny what you mentioned earlier also about the shape of your foot and the proprioception of the foot as well, because one of the things I noticed when dealing with some of the elderly patients is that the ones who have the worst balance are the ones whose feet look like they've been abused over the years and just kind of rammed into the shape of a high heel or a narrow dress shoe kind of thing. And the ones who seem to do better, and this is purely subjective, this isn't anything I did with any research behind it, but the ones with a better balance are the ones whose foot seems to have kept that foot shape. And it's something that, again, only in the last few years I've become more aware of in myself, in the shoes that I'm wearing, and consciously now buy wider fitting shoes, and my foot seems to be returning a little bit to a better shape. But going further past that, then we spoke about the issues of going non-operative. However, obviously as a surgeon, one of the things that you do a lot of is going to obviously be operations. Now, we've spoken about what goes into your decision-making process as to where the patient is, where the objective findings sit, and whether or not you think the patient's going to get any benefit from it, and also where the patient sits on that fence as well, whether they feel like there's going to be any long-term benefits to them going under the knife, or, hey, this is something I can live with for now. I'll try again on a conservative approach and then pump on further. I've seen a fair few patients who have had longer term issues after operations. They're issues that even once their rehab is completed, if they don't train for a period of time, all of a sudden their foot starts to, or their ankle starts to almost seize up. It starts to get swollen all over again. And it's almost like they're not quite back to square one from when they were operated on, but it's almost like they were back to that 2-3 month mark, and then they've got to go through a mini process all over again. Is there anything that we can make out of that in terms of any metal work in the body or anything like that, a kind of reaction?
So, I mean, look, it all depends on the individual and the patient, and it's it's down to so many factors. So let's just step away from feet. Let's talk about my back. Right. So I had cauda equina. I was in a car accident. I had a massive disc prolapse. I ended up having full-blown neurological symptoms, incontinent, feet not working, quite scary. And I had emergency surgery at 2 a.m. And took me 6 weeks or thereabouts to be able to pee properly, get my foot power back. And I was told I'll never be able to have children, all my problems, all that kind of stuff. I had problems. I had problems afterwards. I had really bad pain in the back and leg pain, bilateral, for 2 years. So neurologically, I'm okay, but I've got a lot of pain. Got pain in my legs and my calves, and didn't know what the hell was going on. Got a scan, was totally scar tissue, scar artifact, and some signal changes. It's all scar tissue. Saw a couple of surgeons, told that was all in my head. I was crazy. Everything was fine. Stop complaining. Man up.
It's nice to be taken seriously.
Yeah. Anyway, roughly about 2 years later, excruciating pain, blah, blah, blah. Suddenly, I'm dribbling again. Down below, things aren't working. I've got weakness in my legs again. I'm being rushed back up to hospital. And I have, again, surgery in the middle of the night. I've had corticona twice. When the surgeon comes around in the morning, he goes, "Oh my God, fuck me. You had a massive bit of calcified disc material. When you had your last surgery, they must have missed a bit. And you had really bad canal stenosis. And you had further fresh material come out, and it wiped out your space. And that's what threw you back into." Not my surgeon's fault first time around. It was emergency surgery. Maybe it was he cleared my spine, and then a bit of disc came out and calcified. Don't know. Maybe he missed some. I don't know. I got my neurology back first time around, but I was in crippling pain. And the crippling pain was crippling spinal stenosis for 2 years. No one could figure it out. No one listened to me. They dismissed me, told me just get on with it. Second time round, I got the corticona. They went in and properly cleared everything. Now, that was great. It was successful. I had years of rehab and physiotherapy, and that's what then taught me the value of physiotherapy. Because I realized the surgery is just building a foundation on which you're going to then work on, afterwards with the rehab. The surgery was never a cure for me. I didn't get new, fresh disc. I didn't get a healthy disc back. What did the surgery do? It, reversed the neurological damage, saved me from that point of view, but I've now lost major disc space. Now, at the time, that surgeon said to me, "Your back's never going to be normal. You're going to live with pain for the rest of your life. You're going to have facet joint disease. Don't run, don't cycle, don't do anything, don't play football. And by the time you're 40, you'll need a fusion."
Jeez.
Okay.
That's a medical professional.
Yeah. Now, so the surgery, if you think about it, was to help reverse those neurological changes and the damage done. Now, is my back normal? No. Again, on my Instagram, I posted an MRI of my back. But, what that surgery afforded me the ability to do was, pee properly, have children, walk. And actually, I do exercise. I run. I do jiu-jitsu. I train. I do strength training. And actually, running is great for my back. Movement is great for my back. But is my back normal? Is it 100%? No. If I stop exercising, if I sleep too long on an awkward bed in someone else's house and it's not quite right, my back is stiff. I need to warm up. I need to listen. Does that mean the surgery was a failure? Does that mean the surgery was bad? No. If I hadn't had that surgery, I would have had a very different life.
I totally get where you're coming from, but where I'm looking at this is where people are having issues, and these issues could be explained by a plate that's in their leg,
100%.
that's still there, and they can feel the plate and the plate is awkward, but the surgeon refuses to go back in and says
All
that
right.
none of the issues that they're suffering from
We'll come to
should
that.
have been a bit clearer. Yeah.
Yeah. So we'll come to that. So when take the foot and ankle, when something doesn't go right or they've got symptoms, you need to find the reason for that. Now, most of my patients, I would hope, are totally asymptomatic after they've had surgery. They feel it's essentially normal. But it's not 100% normal because there's a scar there. They may have metalwork in there. So it's not 100% normal. But I always tell my patients, I'm hoping that they're going to be anywhere from 95 to 99% normal, which if they're coming from 25% is like, wow, this is amazing. Great. But if someone turns around and goes, something's not right, I got a little bit of pain, you need to figure out why. So I would always say investigate. And I think a lot of the problems, like I've just alluded to you, is surgeons don't listen. They don't want to know. Their x-ray looks great, the screws look great, it's fine. Why are you complaining? I was dismissed. Why we did an operation, it was great. What's your problem? Just get on with it now. And I think the problem is when we fail to understand or make sense of patient symptoms, rather than dismiss them, we should say our knowledge is lacking. We need to look into this further. And we may need to do more investigations, or actually even sometimes, you know what? I need a bit of a pause. I'm too invested in you. I'm going to go and get the opinion of a colleague of mine. Let's get a fresh take, fresh pair of eyes, looking at your case, and let's say, now, it's funny, I was giving a talk to some GPs a few years ago, and I told them, I'm really happy getting second opinions from my patients. And this very senior GP came up to me and went, I really enjoyed your talk, but I will tell you this, he was an Indian doctor, I will tell you, this is very bad what you said. Never ever get advice from other people. It makes you look stupid. You should always treat your own patients. Don't give to other doctors. Okay, I listened to him and I thought, no, you're wrong. I didn't tell him that in my head. I said, I'm going to respect him and just say, yeah, okay. But that's wrong because that's arrogance. That's, that's ego.
Ego, yeah.
That's ego, right? If you put the patient first and foremost and think, right, my patient's the most important thing. I don't know what's going on. I can't make for consent of this. I'm going to get other people to look at this patient of mine. And maybe they'll come up. Maybe they'll turn around and say, Ahmed, yeah, we've looked at everything. We can't see anything. And then we can reassure the patient. Maybe they'll turn around and go, hey, you know what? I saw this and maybe it's this. And I'll be like, oh, wow, great idea. Didn't think of that. Now, I think like that and think, wow, I can help my patient now. Rather than, oh, God, I look a bit like an idiot. Oh, why didn't I know this? I don't think like that. I think too many doctors, however, do. They think it's embarrassing or it's a sign of weakness to admit that they don't know. And I think we need to put that to side, put the ego to side and say to the patient, I don't know, but I trust you. I believe you. I'm going to look into this. Now, interestingly, I had a footballer today contact me. He goes, he's had a Lisfranc injury. He's fractured, the space of the second metatarsal, Lisfranc injury's done. And delayed presentation, and I operated on him. Doing really well. Crazy individual. He is a machine. Every single time I see him on Instagram, I have panic attacks. I'm like, geez, you've got a plate and screws in there. Just take it easy. But he messaged me saying, Doc, I think I need a scan. Can you organize it? So, I rang him. I said, why do you think you need a scan, mate? Oh, I've got pain in my foot. I just want to make sure everything's all right. Blah, 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 blah. I went, where's the pain? The pain is in his sesamoid. It's nowhere near his operation. It's nowhere near his Metalwork. So then I went, okay. And then we start talking about sesamoiditis and he goes, oh yeah, I've looked it up now. Oh yeah, that's exactly what it is. And this is what I mean. Rather than just say, oh no, it's fine. Your x-rays look fine, because they do. His scans look great. Everything's like, oh no, you don't need a scan. Your foot's fine. Just ask them questions. Now in his situation, I was able to get to a diagnosis, and it's nothing to do with his foot. It's just a new thing. But it might be hardware. Sometimes hardware causes problems. I've seen weird metalwork reactions. Like titanium is meant to be an inert substance. I've seen patients now with metalwork titanium allergy, and it's like, wow, where did this come from? And when you open them up, there's titanium staining of all the soft tissues, and normally you don't see that. Normally, just take the Metalwork out, all the tissues that clean, but you get this weird reaction in people. You get loosening of implants. If you think about bones and joints, there's a slight flex in natural bone, which is why it's made of a bicomposite material. You've got this hard cortical outer structure, honeycomb inner structure. Hard cortex is tough. The honeycomb gives, a bit of flex. You have a bit of both. Now you slap on a rigid metal plate, you will have a stress riser at the junction where you've got the plate bone complex and just the bone. So some people get a stress riser at that junction. So yeah, some of my patients need the Metalwork removed. And sometimes, I will say to patients that I don't really know why you've got pain. You don't have infection. Fusion has worked or whatever. The fracture is healed. Maybe we need to take the plate out and see if that makes a difference. And I don't take Metalwork out very often. It's definitely like less than 5%. Because most people don't need the Metalwork out. But if they've got symptoms and they can't think of anything else, then that's something that I would offer my patients.
Because that is something that is almost impossible to get in the Netherlands. Someone who will acknowledge and reevaluate. So I'll give you another example of another patient who, despite really solid regular physiotherapy, after like a year, 9 months to a year after a total knee replacement, still only had 70 degrees of flexion. The knee was really tight. It just wasn't going further at all. Went back to his surgeon. Surgeon says, no, I put you under, you could go further. It was fine. Don't worry about it. It's your knee. You just need to go further with your physio. He still wasn't happy. I was still a bit perplexed by the situation. So I said, hey, listen, why not consider another opinion? So he did his own legwork and found a clinic that specializes in second opinions on surgeries, revision surgeries, sorry. And he spoke to them. And the first surgeon that he spoke with did exactly what you said there. He said, right, it's an interesting case, but I'm not going to be able to give you an answer today. I'm going to give you a call back in a few weeks, and I'm going to speak to some of my colleagues that are away at the moment. I remember this quite well because it was so interesting to me that they did this. And a few weeks later, he gets a call from them, right? So what we think is going on is that the size knee used was too small. They've also done it too tight, so you don't have the right amount of movement. We want to bring in, we want to take a look, blah, blah, blah. We fast forward, they did a new surgery, and I think at this point he was going on almost 2 years of really, really limited flexion in the knee. And obviously that would affect his ability to ride a bike. We're in Amsterdam after all, and a whole bunch of other things. So also some big effects to his ADLs. After this revision surgery, it was now not instantaneous, but within a few weeks, the range of motion had returned massively. The guy was finally able to get over 90 degrees. And there was us on the physio table back when he was stuck, trying to do manual mobilizations in whatever weird and freaky way we could, which, yeah, all it would have taken was for that first surgeon to go, right, yeah, something's gone a bit miss. We're going to take another look at this and really take another look at this.
Yeah, and I'll be honest with you, probably once every 4 to 6 months, I'll be referring one of my patients away for a second opinion. I don't have a problem with that. It's humility, putting ego aside. I'm actually also privileged to know a good bunch of foot and ankle surgeons in and around London. We have a WhatsApp group. Anonymously and with the patient's permission, we discuss cases that are complex. And I think to my patients, and a lot of my patients are actually second opinions coming to me. I'd say far more. I get second opinions every day in my clinic. And some of them are, most of them I'm like, yeah, I think this is the issue. And some of them are, I'm like, this is really an odd one. We can do two things. I can either wait 2-3 months for the next regional foot and ankle meeting in London, where we all meet up and discuss cases and, put up scans and x-rays. Or, I can put this in a WhatsApp group and discuss it with, 12 of my colleagues now. And the way it works is if someone's got an opinion, they'll give it. if no one really knows and everyone's going scratching their head and going, I don't really know, they'll stay quiet. And we can see what they say. And the patient's like, wow, really? We're like, yeah, because better than my just opinion. Why don't we just see what's out there and let's see what my colleagues say? And they love that. And, and sometimes, it'll be a validation, because I'll be like, look, 4 guys got back to me out of 12, and every single one had a different opinion. This goes to show you this is really unusual, and this is just shit bad luck. And it's really weird. Shit bad luck happens. I got corticoina twice. You know anyone who's had corticoina twice?
Oh, can't say I do.
That shit crazy, man. So weird stuff happens, and that's just life. And sometimes we get the short straw, and there's no explanation, there's no rhyme or reason, but I think being able to just look, I find, one, doctors are very busy, they don't have time. I think too many people don't listen. Doctors are at fault, but I also think other therapists as well. We're fixed in our ideas. We're not open to maybe that we just don't know. Our comprehension, or in this situation, we're clouded. Our judgment, we just can't see through, and we need to get another opinion. My dad, I talked about him. He had lung cancer. He kept going up to his GP and telling him, I've got back pain. I've got back pain. It's between my shoulder blades. It's worse at night. It's really bad. And the doctor's written down mid-thoracic pain, night pain, only 2 red flags. Refer for physiotherapy. I got all the medical records. The physiotherapist has said scapular pain, mid-thoracic, worked 6 treatments, requires another 10. And this went on, and I think he ended up with 30 physiotherapy treatments. 3 years of going backwards and forwards to the GP, being told it's shoulder pain, it's musculoskeletal, only 2 red flags. And by the time I picked it up, long story short, I was at a wedding up for Edinburgh, staying with my dad, and he mentioned this to me. And I got goosebumps. I was like, wow, this is serious. Took him straight up to hospital and said, don't discharge him until you figure out what's wrong. Unfortunately, he didn't tell me what was happening, because he thought, the doctors and GPs and physios are saying it's nothing.
They're not alarmed, so he's not going to bother you.
I'm not going to bother my busy surgeon son. You know what? I'll leave it. But it was too late. And I think, there's a failure there. There's a failure of the GP to take his symptoms serious. There's a failure of the physiotherapist to take the symptoms serious. I think there's a failure to recognize that treatments were not working, so there needed to be a change of plan. Far too often, I will see patients coming back to me with, 20 sessions of physiotherapy, 30 sessions. The record is 56. And that patient, I'd said, look, I'm really disappointed with your physiotherapist, but I have to question, why would you even have 56 sessions? Like, something's not right with you. And they went, yeah, clearly, I'm an idiot. The definition of insanity is to keep doing the same thing and expecting a different outcome. But again, why did the physio or the GP not just say, pause, hold on one sec, things aren't working, 3 years, have we got the diagnosis right? What is this musculoskeletal, scapular, thoracic pain? What is the actual root cause of this? So there's a number of things we can unpick from there. The lack of a proper diagnosis. And too often people I see also on social media saying, oh, the diagnosis isn't that important. Treat the symptoms and do this and do that. Diagnosis is important. Don't give me that bullshit. If you don't have a diagnosis, how do you know what you're treating? How do you know you're doing the right thing? What's the prognosis? What the fuck? I mean, I hate this movement towards, oh no, diagnosis, doctors are obsessed about diagnosis. It's not that important. No. And this, let's move away from surgery, and oh no, doctors and anti this and that. It's balance. It's a balance. But you need a diagnosis. You can't treat something just based on symptoms. That's nonsense. You need to know what the problem is. And then the treatment has to be holistic. So, Yeah, I mean, I'm a foot and ankle surgeon, orthopedic foot and ankle surgeon, but I talk to my patients and I say symptoms. So I'll give an example. I had a patient last week came to see me for a second opinion. Has seen a surgical podiatrist. I said, why did you see a surgical podiatrist? Why are you here to see me? Well, I've had foot pain, on my left, on my right for the last year or two. It's really painful walking. I get swellings in my foot and around the back and the top. And I went to see the surgical podiatrist because my GP said to go and see them. They said, yes, we can cut this out. Let's get a scan to see what it looks like. I got a scan, but there was no lump there anymore because the lumps come and go. And the surgical podiatrist said, oh, I don't know what to cut out. I'm sorry, I can't help you. So he was discharged. And then 2 months later, he finds me and comes to see me. So I take a history. Turns out he's had kidney stones for about 3 years. He's been seeing, some, renal physician or something about this, and urologist. He's had kidney stones. He's told he's got extremely low vitamin D. He's deficient, but he's not to take vitamin D deficient supplements because it will make his kidney stones come back. It was all a bit bizarre and weird. He had bony tenderness everywhere, particularly in his feet, around his ankles, his tibia. And I said, look, I need to do a bone profile. And in particular, I'm going to look at something called parathyroid hormone. And it's come back extremely elevated. He has parathyroidism. Now, the question is it primary, i.e., one of the nodules, he's got a tumor causing extra PTH growth, or is it secondary as a result of calcium or vitamin D deficiency? But that's now in the realms of the endocrinologist and endocrine surgeon to investigate. But he's come to me with painful feet, and you couldn't get further up away from the feet. His problem's here.
Yeah, right at the top.
The treatment is not cutting lumps out of his feet. Now, I could have just, if I was purely fixated in that tunnel vision of, foot surgery, lumps, bumps, cut out, yes, scalpel, yeah, that's not good. It's about taking a step back and thinking, right, let's look at the whole picture, because one thing I've realized, everything is related. And it's funny, so oftentimes patients will say the same thing, like this chap, I said, tell me about your kidney stones. He goes, oh yeah, but no, that's being treated. I don't know if that's relevant. They always say that. I go, no, everything's relevant. And quite often, patients will like, why, you're really interested in this? What's this got to do with his feet? I said, maybe nothing, maybe everything. So we need to step back. We need to give patients time. We need to listen to them. And in our modern, systems of 5-10 minute consultations, quick, and doctors are stressed, tunnel vision. I don't think we really have that full holistic care. Now, I don't want to come across like Ahmed Malik is a saint and the best freaking doctor in the world. Maybe I'm joking. I get things wrong. I don't get things right all the time. And, patients need to give their clinicians slack because we're not perfect. But I think we need to be held to account when we don't listen to patients,
Agreed. Yeah. I was going to ask you what would be your 3 tips to a physio or anyone else listening to this. And I think that's probably one of the biggest ones, right? Listen to your patients.
Oh, yeah. So, I've heard colleagues, bosses describe patients crazy. Sure, I've got some crazy patients. Human beings come in all shapes and sizes and mental dispositions and, stuff going on in their lives. I've been that crazy patient. So, I had crippling pain. I've had surgery and I was written off. My program director thought I was crazy. My colleagues, my bosses thought, oh my God, here's this whinging guy and he's got, what is his issue? Just get on with it, man up, I find patients who suffer with chronic pain, and I've been one of those, you go crazy. Living with chronic pain is horrible. It eats you up. It drains you. It's miserable. And then it's a vicious cycle. You don't move. You don't exercise. Your diet's rubbish. You eat crap. You don't sleep well. And it just, it's just a vicious cycle.
Snowballs out of control.
And trying to break it affects your relationships, your work. You start getting snappy and angry and blah blah blah. And And in my situation, what was really, I think what was driving me insane was no one took me seriously. No one, went, yeah, you know what, there might be a cause. No one gave me a reason for why I was in pain. It was just almost kind of like, look, you're fine. There's nothing wrong with you. Just get on with it. And that was just mentally, I was like, I know there's something not right. And so I always say to people, trust the most scientific thing, which is your gut. This really sensory organ with millions of nerves. Listen to your gut instinct. If your gut instinct is saying something's not right, probably correct. And so with patients, physios, doctors, whatever, look, trust your patients. They're not taking time off work and coming out to see you, spending money or whatever for no reason. They've got better things to do. The fact they're in their room, sitting in front of you, having a conversation, means something's not right. Now, it might not be something that you can deal with. I have patients that come and see me who've got stress at work, who've got difficult relationships, which is probably compounding their symptoms and making it worse. And, and then I direct them away. I've got a patient who, had really bad CRPS and blah, blah. Turns out she's got anxiety. She's got issues with her weight. So, I put her in touch with a therapist. She's making great progress. It's helped her CRPS is really dampened down. It gives her hardly any symptoms. She's mentally in such a good place. She messages me frequently saying, I'm so happy. I was really reluctant about seeing a therapist, but I didn't realize how much baggage I had and problems. Her weight's coming down. She's back horse riding. Now it's positive cycles. We've broken out the negative cycle and into a positive cycle. But here I am as a fit ankle surgeon a doctor primarily thinking, this person needs some mental help, psychological help. Let's get her engaged with that process and let's get her exercising. So she took on board a personal trainer that I recommended, her diet's improved, and now guess what? Her foot's better. And so the answer wasn't, because she's had surgery elsewhere, blah, blah. The answer isn't like, oh, do surgery, more this, oh yeah, this isn't right in your ankle, and maybe we need to do a little bit more, maybe we need to inject it. Why don't we look at the bigger picture? Because everything's related and everything matters. Sleep, diet, hydration, nutrition, exercise, movement,
Yeah, you're a whole person. You're not just a foot or a knee or a shoulder.
Whole person.
Any other tips for the listeners?
I would say, try and put your shoes in the patient and try and experience what they're going through. I think have that humility to sometimes say, look, I don't know. And don't be scared of saying that. I do that once a month, probably. The patients will always turn around and go, but you're the expert. I read your bio and your reviews.
You're supposed to be the magician that fixes me.
You're Magic Malik. I often hear, and I go, look, I'm not going to bullshit you and give you some fake diagnosis. I believe you. I believe your symptoms are real, but everyone's different and your symptoms are atypical. And I'm struggling with my knowledge to understand it. And I'm going to ask for help and other people's opinions. And I promise you one thing, I will keep trying to find out what the issue is as long as you want me to. And you know what? Everyone to date has been like, okay, I accept that. I appreciate that. Thank you. Let's do it. Rather than just say, I think it's that. Oh God, the number of patients that come to me with phony nonsense diagnoses, and just things that are just said to patients because basically they don't want to say, I don't know. Get used to saying, I don't know.
Agreed. Thank you very much. I really, really appreciate your time. And I hope the listeners enjoyed what started off as a conversation about feet, ankles, surgeries, kind of turned into a nice little self-reflection on for all of us to explore our own limitations and recognize them. So no, I think that was quite nice. Thank you very much. Really appreciate it.
I didn't really know where this was going to go. It's such an evolving discipline and specialty, and there's so much to talk about. But I think for me right now, what's even more important is what the topics that I've kind of like discussed with you and you've kind of peeled out, opened up from me, actually is relatable and across multiple disciplines and multiple specialities.
Yeah, agreed. No, I think that everyone can listen to that and take something away from it.
Great chatting to you.
Have a good one.
You too. Bye.
Well, ladies and gents, thanks again for listening in, and we'll catch you next time. As always, wherever you're listening to this, we appreciate your time, and if you have any comments or suggestions, feel free to get in contact and let us know. Until next time, peace.